we've done specifically in the Hudson Valley. And the region's 9 counties, 2.5 million patients. The per capita income goes from the lowest in New York State to the highest. Rural, suburban, urban within this region. We're talking about 5,000, around 5,000 physicians. A third of those are primary care. 25 hospitals in the region. And if you look at the ratio of primary care providers to 100,000 patients, it goes from 22 to 104. So the reason I point this out is it really shows a spectrum that covers about everything you're going to see in the country. And the other thing I'll mention is we do not have an integrated delivery system in the Hudson Valley. We don't have a Geisinger or anything like that. However, Geisinger is right down the road from us. And a lot of what I'll talk about, we've worked with Geisinger on several of what they've accomplished in an open community. We've kind of been a little bit of an experimenting ground for them when we tried to take out some of the principles and projects that they've done within their organization. We've actually rolled those out in the Hudson Valley. But when we started this around 2000, we looked at some IDNs, particularly Geisinger, and looked at the key pieces that you really need to have in an open community to pull this off. One was infrastructure. If you look at things in these IDNs, they all have one kind of cohesive infrastructure. A lot of times they're on Epic, but whatever the case, they're tied together. Transformation efforts are done across care settings, inpatient, ambulatory, all the care settings in kind of enterprise fashion. Transparency, again, looks at various care settings in the whole system. Reimbursement redesign contemplates not just one tiny silo. And then lastly, you've got leadership and governance, kind of looks at the whole enterprise. So when you look at an open community, if you look at us in the Hudson Valley, think about the last slide, and how disparate that is, it's tough to figure out how you handle all of those things. So let me talk about what we've done over the last 15 years and how we got at those pieces. First of all, we created, in terms of leadership, we created one neutral organization, a 501c3, that acts in that governance leadership capacity that includes health plans, hospitals, physicians, consumers, employers, etc. I'm not going to talk a lot about that because this is about primary care and what we've done in that space. But in terms of the health IT infrastructure, we put a big focus on electronic health records, getting electronic health records implemented, and the large groups that we have that are now ACOs, some 300-500 provider organizations that are in our region that we've worked with on various projects, they were already on electronic health records. But if you start to look at all of the other groups, particularly smaller practices, they would still probably not be on those systems. If you look at the Hudson Valley today, over 90% of our providers are on certified, and either MU1 or MU2 certified electronic health records. It's a pretty high number for a community. In addition to that, we ran a health information exchange, and I'm not going to talk a lot about that today. I want to talk about something else that we've recently have started in terms of interoperability and transitions of care. But we have looked at connectivity solutions for those electronic health records during that period of time. And then there's also some analytics work we've done. So again, back to the IT infrastructure comment I made for IDNs, we've come up with a way to start to get at that across the community. Second thing we did is around 2006 or 7, we started to really look at practice transformation focused on primary care and did a lot of work in the patient-centered medical home. At one point, I don't know where we are now, but at one point we had probably the highest number of NCQA Level 3 recognized primary care providers in the country. So there's been a very strong emphasis on patient-centered medical home and all the components about that. I'm just going to assume that most of the audience here knows what all that is in terms of access, team-based care, and all those pieces. A lot of work in that. Then we again went with Geisinger and did essentially what they did on all their primary care practices. We actually had 3 medical directors from Geisinger in our group. work with primary care practices across the region to create that same kind of model. The next thing we did around 2000 is we added the embedded care managers. So we went through risk stratification. Currently we use the AAFP's model, the 6 different levels, and the key is to get that 1 to 2% of the high cost, high risk patients that are eating up so much of the cost. And we train those, again, along the Geisinger model, a little bit around the Mass General's model in terms of some of the centralized component. But we developed an embedded care manager program where we train them and put them in our advanced primary care practices to start going at those high risk, high cost, the hot spotters that Galani talks about, patients. Moving forward, we started to look at different, and again, I'm talking about the different pieces in the last slide. And the next thing we did was looking at, or actually in parallel, we looked at how to evaluate performance in the transparency component. At this juncture right now, we use utilization information from the health plans, so the commercial health plans contribute information from their claims. Also, we're one of the CPC projects, one of the 7 regions that we heard about earlier, so we have access to data from CMS. That is, the analytics are done by Mathematica, so we get that. We are receiving the quality measures from the EHRs under the MU2. And then lastly, we do patient satisfaction caps across all of the region for the primary care. So we're looking at utilization, quality, and patient satisfaction for the primary care practices. Last, as I mentioned, we have several large ACOs in the region that we've done a lot of work on transformation, and then we're also part of the CPC. And when you get into the CPC, you heard earlier that they have measures that they're being evaluated by. They also have technical assistance in each of the regions, so we're the sole source contractors that are doing all the transformation work for the CPC practices. Medicare, as you heard earlier, is paying $20 per member per month, and then the commercials that are part of this are also paying about $10 per member per month. And so that combined amount, which is probably around $100,000 a year per primary care provider, that additional money goes into infrastructure and also personnel. So they can't pocket any of that money. All of that is driven back into the practice to build out the capacity to handle what's being done. And then we work as the transformation agents to help these practices move along. The last piece for that is they are able to do shared savings, which will kick into gear this year, and those numbers will come next spring. I want to point out one thing, because I mentioned that we're very excited about one approach for interoperability on the electronic health records. Back to the infrastructure comment I made before, over 90% of our providers are on electronic health records. And HIE has not really been great for us in terms of transitions of care. We're like every other place in the rest of the country. Half of the time a patient's discharged from a hospital, the primary care doc didn't even know the admission. Half of the time there's a referral from primary care to a specialist, they don't know why they were there, why they were sent. And then half of the time that a specialist sees a primary care provider, they don't get any information back. So part of what was supposed to be done, if you think back about meaningful use, one was about getting these systems in the practices, moving them off paper. Meaningful use 2 is about interoperability. And as much bashing as there's been about not all this money spent and no interoperability, it was actually MU2 when it was supposed to begin. And in MU2, one, the certified electronic health workers have to plug and play into a certain specification on a national network, and to get your dollars, at least 10% of your transactions have to flow over those networks. So we have really leveraged that. And so I'll just talk a little bit about that, and then I'll conclude and turn this over. So direct is about connecting disparate EHRs. And they've got the terminology of a health information service provider, which is the ONC acronym for these networks. All certified, 2014 certified EHRs have to plug and play in these networks. There's 17 of these networks nationally, and essentially every provider that's on an MU2 EHR is able now to transact with other providers. And this, again, is different from traditional health information exchange in that it's a conduit. It's like FedEx. The documents and the information at the provider organization, that EHR, it's encrypted before the send. It's encrypted in transit. You can't stop it, persist it, or open up the data. And when it hits the other side, it's de-encrypted by the EHR and can be ported into the EHR. Here's a typical example. One of the use cases for direct discharge from the hospital. At the time of discharge, the current systems now that are in place before the patient ever even leaves the hospital, there's a structured document out of that EHR that goes into the receiving EHR and can then be managed. We have leveraged this. I spoke about Geisinger, and they'll talk about one of the big factors that reduced cost was getting the information to the care managers on discharge to work with those high-risk patients to knock down their 30-day readmits. We now in the Hudson Valley with our groups, when there's a discharge, that information now consistently is always in the provider's practice and can be utilized for the med reconciliation and all the other pieces that need to be done. One other point about this, as the electronic health records develop their software at each end in terms of the send from one system and the receive from the other system, and they get that workflow so it's improved and usable, you ultimately start to virtualize these systems, almost like you're now laying these systems up against each other. And the workflow and data now you start to virtualize. And if you think about that in terms of a patient-centered medical home moving to a patient-centered medical neighborhood, this is your typical community. If you look at us right now in the Hudson Valley, we have a dozen or so hospitals that are now connected and probably at least 60 different practices. And what starts to happen is you start to, again, virtualize those connections and the flow of workflows to one system. So back to my initial slide, the first thing on the bottom was infrastructure and having a coordinated and integrated virtual infrastructure, and we're starting to finally get there. The last thing I want to mention is we've got the lead article in the Annals of Internal Medicine a couple of months ago was about the Hudson Valley. It came out of the Health Services Group at Cornell. And for the last 5 years, we've been looking at the data on a group of over 1,000 providers, and we have paper-based, electronic health record, and patient-centered medical home in the EHR group. And this is the first 3 years. The 5 years are coming out probably in the first quarter next year, so I'm not going to talk about what those results show. But this showed, again, controls, pre-intervention, and concurrent controls all along. Paper-based versus EHR, no difference in quality. When you added medical home, you had a statistically significant improvement in quality in several areas. And so what we know and what we've learned and what this shows is it's not the electronic health record that necessarily changes the quality, but you cannot get to that level of medical home, population health, risk stratification, et cetera, without those electronic health records. And it's when you get into those advanced practices that you really start to bend the curve on quality. Just stay tuned for the next one because it has the utilization component, and it's very dramatic what you're going to see in the last 2 years of the study. I won't go any further than that.
My name is Rushika Fernadopulle. I'm a primary care doctor based up in Boston. And I think we all know that there's a need for us if we want to fix healthcare to get primary care right? I won't have to argue that with you. I think a lot of the efforts to do it are what we just heard about, which is what I call top-down redesign, starting at the system level and figuring out how do we get the infrastructure and the things to then go down and reach into the primary care practices. And I think that's really important work, but I think we've got to go the other way up too. It's really take time going bottom up. And if we were going to redesign what primary care looks like, how would we do it? And again, I think the vast majority of what's going on out there in the market is what I call incremental change. It's taking existing practices and trying to make them better. And that's great because we have to do that. But the problem is I don't think we have a vision of where we're going. If we don't know where we're going, how do we know how to get there? And so the task that we've set about in the last 10 years really is, what if we decided that this is a big enough problem that in addition to helping the existing guys get better, we should start over. And we should actually create a vision of where this ought to look like and not feel like we have to start with what we have, right? And it's funny, in any other industry, if the existing incumbents were doing so poorly, which they are, by the way, there would be new entrants who come in who would break the rules and just decide to do things better. Think Southwest Airlines in the airline industry, you can go down the list. And so that's what we are. So we are a very small company based in Cambridge, Massachusetts. We call ourselves a social venture because our mission is to actually transform care. But we're going to do it not by talking about it or thinking about it, but simply building a model that we think works and figuring out how to do it at the 5-foot level, right? So I think it's obvious what to do at the 35,000-foot level, but how does it actually play out? And then demonstrate that this thing really works. So if you want to fix primary care, I think it's a three-legged stool, and there are three things you've got to fix. You've got to fix all three of them simultaneously. Like a three-legged stool, if you fix one or two and don't fix the other one, it collapses. The first is payment redesign, right? I think the proposition that fee-for-service is fundamentally the wrong way to pay for primary care. Primary care is about continuous healing relationships. You don't pay for relationships based on transactions, right? I think one of the problems we've gotten into in healthcare in the US is we've turned it into a series of transactions. And a lot of things we're trying to do to fix it, meaningful use, medical homes, are adding more transactions into the mix. It's not clear to me that actually gets us to where we want to go. And the thing that I think, in sum, what we're trying to do is get people to change behavior and to heal them. The thing that changes behavior and heals people is actually relationships. It's not transactions. So stop the madness, pay us a fixed fee for the primary care. Let us stop perseverating over the level 3 versus level 4 and which boxes we check and EOBs and just get on with it, right? It's ridiculously ineffective. So really, change the payment, no fee for service, period. We run pure play practices where we don't do any of that. Fixed fee for primary care. Number 2 is let's put more money into primary care. Primary care is typically 4 or 5% of the healthcare dollar. That's ridiculous, right? It means 96% of what we pay for in this country is failure of primary care. It seems like a really poor investment philosophy to me. So we sort of double down on it. And by the way, none of this $10 PMPM crap, right? Come on, if you're serious about this, put some real money onto it, right? So 50, 100, right? Double it, triple it, right? A little bit won't make it better, right? And I think the thing we do always in healthcare, we've done this too many times, is we sort of have a good idea and we water it down and then we put the watered down thing in place or bastardized thing in place and then we're surprised it doesn't work and we throw the whole thing out, right? So let's not do the half-assed solution. If we think we're serious and this is important, let's actually do it for real. We get offered, Aetna offered us a $5 PMPM, kicker on the case for it. I think you've got to be kidding me. We're wasting our time if that's what we're doing, right? So we double the cost of primary care, right? Double the amount going in, and then all we have to do is save money on the back end by keeping people out of the hospital or the ER, right? So it's fixed payment. Number 2 is that allows you to completely change the process model. This is not a little different. This is very different. I think even the best level 3 medical homes still unfortunately perceive their job as do the best job I can with each patient in front of me, largely because that's what the payment model tells them. That's not the right job for primary care. The right job for primary care is I have a population of people, they are my problem. My job is improve their health and keep them out of trouble, right? It's actually not a little different, it's completely different. So it means you completely change how you run your day, and I'll talk about that. And then the third is, when you start doing that, you realize that the IT systems we have, even the good ones like Epic, right, are not surprisingly built for the old world. They're built to help you document, code, and bill higher. They are transactional in nature. They are built for throughput. They're not built for population management, engaging patients, running teams, all the things we have to do, right? And you can't get from here to there. So again, in the spirit of let's create a vision of where we want to go, let's throw these things out and start over and build a system that actually work. So we had to build our own IT platform. So again, so number point one is we have to get the payment right. So our strategy is let's go after payers who are willing to pay us differently. And I think as you heard in the session before, a great target are self-insured employers, right? People who are on the hook for healthcare costs, who have long-term workforces, who are willing to make investments. And union trusts, by the way, are even better because they get it. They get that there's a zero-sum, trade-off. So this is one of our first practices we built about 3.5 years ago. It's with the Casino Workers Union Trust in Las Vegas, United HERE. They provide health care to the back of the house workers, the maids, the dishwashers, low wage, largely immigrant, the back of the house folks, right at the foot of the stratosphere. And so we opened a practice to start serving the sickest 10% of them. And let's see if we can create a difference. We get paid a fixed fee, double typical primary care, no coding, no billing. Let's just get on with it. So first about the team, right? So what do these teams look like? And again, this is very detailed stuff, but again, the devil's in the details. It's not the 35,000 foot stuff. So here's our team. The first thing you notice, there are only 2 doctors in this team, myself and Eva Snow in the back, right? So we have no coding, no billing staff, because we don't bill. Our billing's a 1-line email once a month. We have this many patients, here's the rate, send us a check, right? So that's easy. So we can focus on the population. So we have one nurse, Carolina, who's in the middle there. We have a social worker, that's really important, Sarah, who's standing next to me, because so much of the barrier to people getting good care, particularly low-income folks, is social issues or mental health. And so you need to, good luck trying to find a psychiatrist to send them to, right? So bring it into the practice, do warm handoffs so people can come without a stigma. Everyone else there are people what we call health coaches, right? So when you think that your job is, you have a population of people, you want to keep them out of trouble, the hard part isn't what I do, which is diagnosis and treatment. That's pretty obvious. The hard part is how do the patients actually use that advice to change behavior. Think about it, the bulk of this is chronic disease, right? That's what's killing us. The way I see a diabetic now is I see them 4 times a year if I'm lucky, every 3 months. I have 7 minutes with them, and I sort of tweak their medications, and I say, you should eat better, exercise more, check your blood sugars, good luck, sucker, see you in 3 months, right? That's what we do. And then we're surprised we get bad outcomes. Like, of course we do, right? So there's 1,000 steps between that of let me understand my condition, what do I track, someone to hold my hand when that's the right thing to do, someone kick me in the behind it when I get a cookie like I just did, right? You need that, and I'm a wrong person for that, right? I'm too expensive, and I'm not good at it, it's not what I got selected for, and nurses aren't good for it either, to be honest, right? So we said the only skill you need is empathy, connecting with another human being, and I can find that anywhere, and I cannot teach it. So hire for empathy, train for skill. So these people come from everywhere. So Janima on the right, she was a hot yoga instructor in Las Vegas. Alex in the back was a softball coach. Dennis with the tie worked at Target. Barbara in the back was a food and beverage server at Sahara, right? I don't care where they come from. What's more important actually is they live the life of the patients they serve and can connect with them. I mean, I can teach them all the medical stuff, that's easy. We have 4 of these folks per doctor, by the way. So during the day, we start each day off with a huddle, right? So again, 45 minutes. A lot of people run huddles in the medical home for 5 minutes where they all stand around and talk about the people coming in today. Yeah, but they're coming in, we'll figure it out. The hard part is we should talk about the people who are not coming in, right? Who are getting into trouble. People who are coming in, they're fine, we'll figure it out. The problem is that 95% of your population is not coming in today. And you've got to figure out who's getting into trouble and what should you do about it to reach out to them. Again, think about it. We sit in our primary care practices waiting for people to come in. That's a stupid way to manage the population, right? We need to spend at least half our time reaching out as opposed to waiting for people to come in. So we make a plan, what are you going to do? Little things. So one comment people make is, I can't tell who the doctor is, right? So the doctor does not run the huddle, right? The first thing we say every day is we all run the practice, we all run the huddle, and we take turns. So I do get to run the huddle, 1 day out of about 12, but so does the operations assistant, so does the health coaches, so does the nurse, so does the social worker, right? Completely changes things when you do that, right? So again, it's a sum of a lot of tiny little pieces, not the do you have a policy to see people within 3 days, right? It's micro level stuff you've got to get right. So we see people in the office, of course, we see them in visits. We make sure that every visit they see the health coach first, then see the doc, and then the health coach, closes the loop. Every visit starts in real clothes, sitting at the same level, not you in a paper gown, perched at the edge of a seat, doctor walking in. So then people say, well, that's not efficient, and I say, who cares, right? The point is, primary care is 4% of healthcare spend. who cares if you make it more efficient? Right? It's rounding error. The thing to worry about is 100%. And if by doing a real conversation real close, you can affect the 96 and makes it 4% more inefficient, who cares, right? So again, it's about thinking about the big picture. We do about half our interactions, by the way, non-visit based. It's 2014, come on, and making people come in to give them their lab results and things is ridiculous. When we schedule visits, people can choose. I want a video chat, a phone call, or in person. We're sort of indifferent. A lot of outbound stuff as well. Lots of groups. Groups are a great way to get patients to interact with each other, right? Health is social. This is about learning how to live with diseases, and patients are better at teaching other patients at it than I am teaching them. So we call them clubs, by the way. No one wants to go to group, or no one wants to be in a class. Everyone wants to be in a club. So it's diabetes clubs, we have Zumba clubs, we've got, this is a yoga club we do in the Prospect Park in Brooklyn on Saturdays. You know, so people love it. They learn to support each other, and they're sort of fun. The point is, again, is do whatever it takes to improve the life of the patient and keep them out of trouble. So we go grocery shopping with people a lot. So we found that a huge part of getting people better is getting them to eat better. I can give them every class I want with a chalk talk or PowerPoint, ineffective. What we do is we have a health coach go to them to the grocery store, your grocery store. Go pick up the stuff you would buy. Great, now let's look at the labels. Why is this a bad idea? Let's go together and find something that's actually a better choice, right? It's amazing how a 1 hour shopping trip can impact people's eating habits for a lifetime, right? People say that's inefficient. Like, that's the most efficient thing we can do, right? Little things, focus on the service stuff, like healthcare is a service business, and also just innovate. So we had one of our phlebotomists, who said, people hate getting their blood drawn. Can I make it fun, doc? Can I order one of every Band-Aid in the catalog? I was like, sure. So she ordered one of every Band-Aid in the catalog. So now when people draw their blood, she says beforehand, let's pick what Band-Aid you want. These are adults. These are not kids, by the way. I want an Angry Birds one. I want a Captain America one, right? It completely changes the nature of the conversation. This costs us, $5 per Band-Aid box, right? Really simple thing, but the key is you encourage sort of innovation from the bottom. IT system, right? So we have had to build something different. You cannot do this sort of care without pain, right? It gets in the way. It completely gets in the way. It forces you to put all this junk in you didn't do, so you can generate the level 4 bill that doesn't prove value. So really, this is more what I call a PRM, a patient relationship management system, than an EMR. It's about managing the relationship. Again, take pieces that people have, document management in this box, we use an open source HL7 integration engine, but the bigger point is the EMR, the guys who write this work for me and only for me. And so we do agile development, 2-week iterations. So every time we change our workflow, they change the system, right? As opposed to in prior practices, you get in the epic development queue, like good luck in 2 years getting your thing fixed, right? So again, tail shouldn't wag the dog should wag the tail. So we're tiny. We're doing this. We just opened up our 10th center last week in Phoenix. We're opening our 11th next week in Phoenix. In general, what we're getting tracked, we started with self-insured employers and union trusts, the Culinary Fund, Dartmouth College, the Carpenters Union. We've just started now opening and moving into the Medicare Advantage business. I think this model works unbelievably well for MA patients, and we've opened Medicare Advantage practices in Seattle and Phoenix over the past couple weeks. And we're starting to work in the exchanges. So we have a couple places in New York and in Nevada where we're bundling our practice with a wraparound health insurance plan and offering it on the exchange. So you can buy a United plan, which is, the usual fine print, little book and a card, good luck getting care sucker. Or you can come to one of our practices, take a yoga class, have a glass of wine, take a cooking class, meet a health coach, have a doctor, feel like someone's taking care of you. By the way, there's an insurance plan, and we'll help you spend your money that's in between there, and it's the same price, right? So it's a pretty compelling consumer proposition. So this sounds good. Do patients love it? Of course they love it, right? This is a completely different one. These are not a little different than typical practices. They're completely different. We have net promoter scores in the 85 to 90% range routinely, which is really hard if any of you have tried to do that. And people really like it. Our outcomes are great. So people come into our practices, 50 or 55% are under control with hypertension. We're now about 90, by the way. These are sort of old data. So we can get that degree of diabetes control. And it's just having systems in place. And economics, case control study, you take our patients, match them to a control, follow them across. And this is from the Culinary Union. So 37% drop in hospitalizations, a 12% drop net in total spend. We've done this several times now. Of course you keep people out of the back end, right? And by the way, this is 1 year data. So this is not even taking credit for the better health, right? That'll come later, and that's going to make this even better. And then if I'll close with the fourth aim, people all talk about the triple aim in healthcare. Part of why I'm doing this is that I think too often efforts we have to try and fix healthcare in general are done at the expense of our teams, right? Just make them work harder. We just add things to what they do already. That's not a very sustainable thing to do. And so our providers love it. Our teams love it. This is one of our practices in Las Vegas. And the way you do that is you take things away, right? And we get to do that by starting over. So again, I think if we want to fix healthcare, we have to fix primary care. I think it's great that we're making incremental changes to existing practices, but I also think it's shocking there aren't more of us doing this. We ought to have the courage to also say, why don't we start over and simply build visions of what this really ought to look like, and that, to be honest, will sort of kick the rest of the industry into moving a little faster. So thank you.